Hi, it's Dr. Centeno, and thanks so much for joining us today. Today we're going to go over an interesting topic. And as you know, much of my career now is devoted to trying to help patients avoid craniocervical instability surgery or an upper cervical fusion. Having said that, there are times that we can't help patients do that, or they're just patients who aren't a great candidate for that kind of treatment and probably need to get a surgical opinion. So we're going to go into today who is more likely to require a surgical opinion, and at the same time talk a little bit about the different surgeons that do elective uh, surgery in this area, elective upper cervical fusion surgery. Now, as usual, we're going to start with a short presentation that I'll give, but then we'll go right into Q&A. So if you're on YouTube or on Facebook, just put your question in the comments and I'll be able to see those. They'll all aggregate on my end, and then I'll be able to answer your question. So again, we're going to start with which patients need CCI fusion surgery, then talk a little bit about the different surgeons that offer that kind of procedure, and then we'll get into the standard Q&A that we normally do. Just going to give a minute or two for people to log on. It looks like we've got a bunch of people interested in this particular topic. So just for one last time review, we're going to start with which patients need CCI fusion surgery, and then we'll get into the different surgeons that offer that surgery, and then we'll get into a Q&A. Just put your question in the comment, and I'll see all the comments here, and then I can obviously answer questions from there. So let's start here. Which patients need CCI fusion surgery? Where should I go? So the first thing is this discussion excludes upper cervical fractures and severe upper cervical instability. We're focusing instead on the thousands of patients who undergo elective craniocervical instability surgery each year, usually some sort of upper cervical fusion with various other parts and pieces. So there might be, for example, a C1, C2 screw fixation fusion, or a Golden Harms type fusion, or with or without decompression of the skull base, etc. So lots of different options, but we're focusing, again, not on people who get into a huge car crash and have an obvious case of upper cervical instability, but instead on the elective patients that get operated, where craniocervical instability is discovered in the course of time as the cause of their ongoing disabling symptoms. So most patients with CCI don't need surgery. That's the good news. About 80% of the patients that I see don't need surgery. So now, we certainly have patients that I see where, and that's thankfully pretty rare, where I've identified them as being a surgical candidate, and even patients where I have refused to treat them because they're such an immediate surgical candidate that it's not a good idea to undergo non-surgical care. Now, what I'm going to focus on today is the patients who are more likely to need a surgical consult earlier. Now, doesn't mean we may not be able to help some of these patients. It just means that these are patients who are probably going to go towards surgery, certainly if we can't help them. So this is sort of my list of things that really require an early surgical consult, and patients really need to start considering out of the gate that they could need a surgical fusion. So that's going to be, I'll go through each one of these, a high ADI, a very low CXA, significant static compression on the brainstem, severe Chiari, not talking about Chiari 0 CTE or Chiari 1, but talking about 1 plus, 2, 3, etc. Severe congenital abnormalities of the upper cervical spine. A patient who just can't tolerate, due to medical reasons, usually an ePICL procedure, and the failure of a real eIPL procedure with continued disabling symptoms. So high ADI. Now, ADI is this distance in front here, right? This is the atlas, this is the dens, and the distance between those two we call the atlantodental interspace, or ADI. And normally, if this is over 7 millimeters, I start to get very concerned. We've seen patients in the 5 to 7 millimeter range where we have confirmed that they still have a good transverse ligament on very specific type of MRI imaging where we've been able to help those patients. Having said that, we've also seen patients at 7, 8, 9, 10 millimeters where I've just recommended that they get a surgical consult. Now, the first thing is that they have to be unstable here, right? So that means that it might be 7 millimeters in flexion when they're looking down, but when they come back up, maybe it goes to 3 millimeters. Or let's say it's 5 millimeters, and it's 5 millimeters whether they're in flexion or they're neutral. Those tend to be cases that I would consider more for a PICL procedure or an ePICL procedure. So high ADI is one where we've got to start thinking about surgery. I've had maybe 2 or 3 of these in the last year or so, where I've just said you really need to get a surgical consult. Another one would be a very low CXA. Now, you've got to be careful with this because, first off, a CXA is going to be this angle between the Bayesian and basically the dens. And a couple different ways to draw this, to take this angle, etc. But the bottom line is that if you look at the Nicholson paper, which is the best we have in upright MRI right now, you can get down to about 126 degrees and still be within the normal range of people walking around out there. Now, that's very different than most of the patients I see where they're told frequently online or in social media groups that if you've got anything lower than 135, that's a problem. It's not. Up to 126 degrees is within the normal range. But once we start getting near that 120 degrees, that's when we start to become concerned, not only because it's below the value that's out there in people walking around, but also because that's when Henderson's research showed that we started to get too much stretch force on the brainstem and the spinal cord. Obviously, there's got to be severe disability due to this. So just having 120 degrees and having few symptoms doesn't qualify. Another thing to consider fusion would be significant static compression of the brainstem. Now, it's very important that you realize that this is not what I call the social media definition of basilar invagination. In fact, most of the patients who claim they have basilar invagination because they have one or more lines, McRae's line, etc., violated, really do not have basilar invagination. Basilar invagination is what you see here. That's where the dens goes up into the foramen magnum, and there's clear pressure and change in shape on the medulla. So this isn't contact of the dens against the medulla or the upper spinal cord. This is compression that changes the shape of that structure, and more akin to something like this. Now, of the different patients I have seen on social media, far fewer than 1% who believe they have basilar invagination or compression of their brainstem have anything that looks like this. So again, be very, very careful here because this is not the social media definition of basilar invagination, but it's the true surgical definition of basilar invagination. Another one would be severe Chiari, and that's going to be, again, not a Chiari 1. because Chiari 1s are common without symptoms. Chiari 0s are common without symptoms. But it's going to be a Chiari 1 plus, a Chiari 2, Chiari 3, and there's a syrinx due to clear backup of the cerebrospinal fluid, and then disabling symptoms due to that. Another thing to consider surgical fusion would be severe congenital abnormalities of the upper cervical spine. So this is usually severe instability related to congenital absence of the axis or really a chunk of it. For example, absence of the posterior arch of the atlas where the transverse ligament isn't fully developed would be a good example here. Again, the way for us to look at this is we can look at CT scans, we can look at high quality MRIs of this area. We can also look at a high quality MRI of the transverse ligament and try to see if it's intact, for example. And another one of these is going to be unable to tolerate an ePICL procedure. So this is someone who's not medically cleared for an outpatient procedure. So the things I've seen show up in the office are an inability to position the patient in any way, shape, or form, even if we make compromises with that patient. I only have seen a few of those through the years, but we've seen a few. Difficulty in keeping the patient asleep during the procedure for various reasons. That could be medication related, but oftentimes it's because the patient is on lots and lots of different drugs, and it's too difficult to keep the patient asleep while we're working through the airway. Again, very rare. Poor pain control pre-procedure. This is one that can become a big issue. If you can't control your pain with any medication that exists pre-procedure, how are we going to control it after the procedure? And then we've seen a few patients through the years who are just medically unstable and really not cleared for an outpatient procedure. They need to be in an inpatient setting to keep them safe. And then finally, is failure of a real or actual ePICL procedure with continued disabling symptoms. Now, this is not the failure of what I call a fake and bake PICL procedure that's available in Europe or India. There's a gal in Hungary who's faking and baking a PICL procedure based on what I've seen. We've got another guy in Europe. There's a guy in India. These are not ePICL procedures. They're not the procedure that I developed. So if you fail that, I've got no idea whether you're going to respond to a real ePICL procedure. So that's not going to count, regrettably, because you didn't actually get the procedure that I know is effective. So in my decision making, you still got to get the real procedure and fail that. So if you need surgery, where should you consider going? Well, the big problem we have here is that you can find spine surgeons in a university setting who perform upper cervical fusions a few times a year, usually on these patients that come from the ER with their head falling off. The problem is that only doing a procedure a couple times a year, you're not expert in that procedure. You're kind of, you're operating at some level of expertise, but it's not a high level of expertise. So if you've got a problem that doesn't need urgent emergent surgery yesterday, then you can look around for the surgeons who do this all day, every day, because surgeons are no different than anyone else. Doctors are no different than anyone else. If they do something a lot, they're going to get very good at it. If they do something infrequently, they're going to be pretty bad at it, or at least not as good at it as they could be. So in my experience, regrettably, we only have about 5 surgeons worldwide that do about 80% of the elective CCI surgery. There are 4 in the United States. We have Dr. Bolognese in New Jersey. We've got Dr. Henderson. He's in Maryland. We've got Dr. Sunil Patel. He's in South Carolina. And we've got Dr. Joel Frank in Florida. These are the 4 in the U.S. who I can vouch for that they do this surgery all day, every day. Now, one of the things you have to be very careful of in social media land is I've seen patients, wow, Dr. So-and-so, I met two people who had a bad result with him. You might have met two people who had a bad result who were very loud about it on social media, but you didn't see the other 100 patients that did quite well. So be very careful with the social media telephone effect. It's quite real. It's one of the reasons why I make fun of CCI influencers online or on Reddit or on Facebook, because they don't really get the true picture of what's happening. It's one of the reasons why I started doing the As Seen case series in my office, because even ePICL outcomes were being totally misrepresented by CCI influencers who had no idea which end is up. So again, just because you see something bad about one or two of these surgeons doesn't really get you to the point of understanding their total body of work. Now, if you want to ask me during a telemedicine, my personal opinions of each of these, I'm happy to share those with you. And I'll give you my sense of who I think probably has higher complication rates based on all of the patients I've seen, because I'm seeing these patients as a series, not just sort of relying on the social media telephone game effect. And then in Europe, we've got one guy, Dr. Gillette's clinic. There are surgeons there and sort of a cadre of surgeons within Barcelona. I'm just going to use Gillette here and focus on Barcelona. So in summary, some CCI patients do need elective surgical fusion. If you do, you want to seek out a surgeon that does this all day, every day, not some surgeon that might do it a couple times a year. And that really limits us to about 5 different centers where most of this surgery is done. Okay, guys, we are now going to go to some questions here. Let's see. Carol Yates, submitted advance by Sherry Scott. Would surgery in my lower neck eliminate me from getting a PICL procedure? No, not necessarily. Now, if it's a fusion or an artificial disc, which acts like a fusion, that could put more pressure on the upper cervical spine. So it might make the upper cervical spine harder to treat. So I would only get a discectomy and laminectomy. I would not sign up for a surgical fusion or an artificial disc replacement, which acts exactly like a fusion. And before I answer another question, guys, if you found this and you know about this particular thread that I do every Sunday, do me a favor and give me a like, share, subscribe right now, just because that helps other people find this. So if you want to pay it forward to other patients in the CCI community, do that for me, because that'll help them find this as well. Nava, sorry. Dr. Centeno, do you recommend a neurosurgeon in Colorado that could take a look at my case, or a good PT? I've gotten an upright MRI, specifically CCJ. I've been to multiple doctors and haven't gotten answers. Instead, they just ordered a pain management for nerve blocks. Well, Nava, we're in Colorado, so my recommendation would be that you get an appointment in the clinic, that Centeno Schultz Clinic in Broomfield. There isn't any CCI surgeon in Colorado. That doesn't exist, meaning that there is no surgeon in Colorado that has enough CCI experience on a day-to-day basis for me to recommend that they do an upper cervical fusion. But we're in Colorado, we're just in Broomfield. So since you happen to be close, it'd be a good idea to come in and see one of the doctors in our clinic so that we can see what might make sense for you. Because obviously, right, it's not like you're in Turkey and we're in Colorado. You're in Colorado, we're in Colorado. I do not know how to read Cyrillic, so I'm not going to try. Hi, Dr. Centeno. I wonder who I can ask to give me a referral for X-ray in Europe from CSC. I've emailed your assistant, Terry Ryder, hope to get the right person to ask this. Prior, I had a PICL with you in 2022, made sustainable progress. Hope to have a telemed with you. That would be Ryder. And that would also be going through and I don't think you can get a DMX in Europe, but you can get something similar. So let me switch the share here. So if you go to my YouTube channel, this one right here, how to use X-ray DDR for CCI diagnosis would probably be the way to go to try to get some follow-up movement-based imaging done in Europe. Stephen, would you say a PRP can be? Now, I didn't get all of that, Stephen, so I don't know what the question is. Maybe I'll pick it up later here. It all started with a domestic assault injury to the neck, and then I had a bad fall about a year later, and then went to a bad chiropractor in Mexico, and I felt so much worse since. Yeah, like I said, Nava, if you're in Colorado, we're in Colorado, so I'm sure a lot of these people who are on this Facebook Live right now would kill to live in Colorado, right? They have this problem, they have to travel. So we're just down the street. So I would come in and have us take a look. Amanda, I don't have access to upright MRI, but I do have a supine cervical MRI. From that, it looks like I might have a low CXA. Is there a correlation between low CXA and a retroflex stens? I'm assuming if I did have flexion-based imaging, that CXA measurement would be even smaller. So to kind of break that down, we can take a CXA measurement off a routine supine, lie face up in a tube MRI, number one. Number two is if you have a retroflex dens or a dens that tends to go backwards towards the spinal cord, that's going to reduce the CXA. And then all of that needs to be looked at in context during a telemedicine. Now, during a telemedicine, with me at least, I'm going to require that you have movement-based imaging because a supine MRI is not enough in order for us to make that time that we spend together useful. So a digital motion X-ray would be one thing to consider. You can use various X-ray types, just like the video I pointed to try to see if you can get something similar to a DMX or an upright MRI with flexion and extension. Supine MRI is not going to be enough to diagnose craniocervical instability or for us to really get much information in most circumstances. Carol, submitted advanced by Harry Winston. Dr. Centeno found that sleeping on my side with pillows, supporting my neck is less painful and lets me get more sleep. Does that sound okay if it's working for me? I mean, in general, Harry, but you'd need to be my patient with me having performed a complex analysis of your situation to really make any specific recommendations there. Zach, do all Centeno Schultz doctors do video consults? You just only do phone consults. Video consults much more personal, allow a person to share their screen. Yeah, Zach, we all do video consults for sure. Zach, how much BMC volume can be used in one visit? If I get a PICL, I'd like to treat my hip, labor, and knees at the same time. Zach, that really depends on your size, your hematocrit level, and other things, but there are certainly ways to treat the hip and the knees at the same time. Submitted advanced by Sherry Scott. Are there any surgeons that you would recommend in the U.S. if you do need surgery? Sherry, I went over that. Probably you submitted that before. Manifested joy. What if your CXA is 132? You have a lot of neurologic symptoms. Your neck feels very loose. And you have tried 2 PICLs, countless protherapy, and stem cells injections. Would surgery be needed? Joy, I would need to know more information. But in general, a CXA of 132 wouldn't be considered pathologic based on the information we have if taken off an upright MRI. Now, there could be many other types of craniocervical instability, or there may be many other things causing your symptoms. So it's impossible for me to answer a specific question like this without a lot more information. So for instance, you had 2 PICLs. Was it a real PICL? Was it an ePICL? Was it a fake and bake European PICL? I don't know the answer to that. What type of prolotherapy did you have? Was it with imaging, without imaging? If so, what kind of imaging? Who did it? What type of stem cell injections did you have? Were they bone marrow concentrate? Were they fake umbilical cord stem cells? So too many variables in there for me to really figure out what's up. Recently joined Regenix, and I'm really impressed. It's possible to visit a clinic in Colorado. Yeah, I don't know who's asking the question. Not to learn upper cervical work, no. That's a by invitation only for various providers. So we have a Florida clinic we're working with right now, but it's by invitation only. So that would not be possible to visit my clinic and get any upper cervical training. I've been burned by that, and had one person show up and then be told that she was not qualified to do the procedure, and then start offering it in Hungary, for example. So no, not a possibility for this stuff. Too much risk involved. Julie, as a patient with a very low CXA and a hyperlordosis, most likely caused by forward head posture, poor upper thoracic posture over the years, how much can a correction of posture improve the CXA? Yeah, Julie, I think we've had this conversation now many, many years, many times, but I think it's important as a general concept for everyone to understand. Many patients have low CXAs. They have no issues at all. And then something sets it off. So let's say a patient goes and they're a big bike rider and they go on a very long bike ride and they're down on the drops like this and their head up like that for a very long time. Plus they're getting older and they're getting degenerative instability with time. And all of a sudden now that becomes important and it becomes symptomatic. It was the same the year before that. The imaging was the same the year before that. There were no symptoms. So again, we need to make sure that we understand that when we talk about all these angles, we're really talking about people who are more likely to be symptomatic, but the imaging by itself is totally meaningless. So it's important to realize that low CXA, high CXA makes no difference whatsoever unless it's put in the context of that patient, and that there are lots of people walking around with low CXAs who have no problems whatsoever. And in fact, they may develop problems later at a later date, and they also don't need their CXA changed in all likelihood in order to get better. So again, be careful with these numbers because patients believe that these numbers, I think, are more than they are. They are merely part of the puzzle in figuring out why someone is symptomatic, but they are not the whole puzzle by any stretch of the imagination. Hold on a second here, Snowmass. At our Centeno, what imaging would show transverse ligament formation and condition? Upright MRI, supine MRI, are they fine enough to see clearly? Upright MRI is not a great way to image transverse alar, accessory ligaments, etc. The best way to do that would be a closed bore 3 Tesla magnet with a head coil. The purpose of a head coil is to get much more information about those ligaments. Upright MRI would be the least likely to give us a clear shot of those ligaments. We can get them, but those images are going to be lower quality than a closed bore MRI. Do you recommend Dr. Buchanan in Colorado? I don't know who Dr. Buchanan is. Let's see here, Nava. Yeah, so Nava, again, I think the discussion I'm going to go back to is that when it comes to CCI surgery, we need doctors that do this kind of surgery all day, every day. I don't know of any Colorado physician that does, let's say, at least 100 upper cervical fusions a year. Consequently, I can't recommend any Colorado spine surgeon. Now, I know the people on the list that I've already discussed are in that league. They do at least 100 cases like this a year, hence they're going to be expert in it. But a doctor who does this a couple times a year, I can't recommend. Casein, I thought I heard you say that hypertonic dextrose leads to better quality collagen in HEDS patients than PRP stem cells. Did I get that right? I can only tell you that in my clinical experience with patients who have hypermobile EDS, and remember, there are different genetic variants there. So I'm talking about most of the patients I see. It tends to go prolotherapy or hypertonic dextrose works well. PRP seems to work a little bit less in their ligaments than prolotherapy, but bone marrow concentrate works better than prolotherapy. That's just based on my personal experience with that patient population through the years. John, with Chiari CTE, how does PIC help if no symptoms were present prior to injury? Yeah, John, be a good idea to go and spend some time looking at the videos on that topic. I've got a couple. So if you go to my YouTube channel, just look up Chiari, and you'll see a bunch of videos that have been done on that topic. Basically, the concept is that CTE is totally normal. There's nothing abnormal about CTE. There's lots and lots of people, it's a Chiari 0, walking around with a Chiari 0 who have no issues. If you then add in cervical instability plus CTE, you then tend to get symptoms. So you got to get rid of the cervical instability component, or that's through specific injections, or that's through a fusion. That's the approach. In general, CTE doesn't need to be decompressed, or you don't need any surgery for that. You've got to get rid of the thing that's really causing the symptoms, which would be the instability. Before the instability, again, lots of people are walking around with CTE, no issues. Michaela, you got to put your questions in the comments, and then I can see them, and I'm happy to answer them. Edgar, would a DMX catch most of these upright MRI issues you just described? Would you highly recommend upright MRI on top of the DMX? So again, Edgar, if we had to pick one technology that's the most likely to pick up CCI if it's present, now there's 8 different types of CCI, that would be a DMX. The second in line would be an upright MRI. And they each can find different kinds of CCI, but the DMX tends to find the more common types. So I'll never turn away additional information. What I'd really, so if you want to get a DMX and an upright MRI, that's wonderful. If cost is an issue and you are trying desperately to preserve funds, then I would say start with a DMX, and then we'll see what you need from there. HRH, what happens after several PICLs and one side is no longer pathological, but the other side is still 3.1? Well, the good news is 3.1 is right on the cusp of being normal, abnormal, because you get up to 3 to 4 millimeters. So my guess is maybe an additional PICL if you're still symptomatic, but that would obviously have to be looked at on a case-by-case basis. John, would you recommend myofascial release 3 months after a PICL? Sure, John. A lot of that's going to depend on how you responded to myofascial release before, right? Many of our CCI patients need spasm in the muscles to provide stability. Now, that's why, for example, many times if they get their muscles worked on with massage or myofascial release, or even dry needling or Botox, all things that can relax the muscles, they have less stability and then more symptoms. Now, for some of our CCI patients, it doesn't work that way. They get specific muscles worked on and it feels great. So if it felt great before, you can do it after. If you've never tried it, be a little careful, because sometimes, like I said, making those muscles looser can increase the instability. Stephen, would you say it's important for CCI patients to watch out for foods that cause inflammation, leading to symptomatic flare-up? Can make a good video topic to help patients. Yeah, listen, Stephen, if you're eating a lot of foods that are very inflammatory, I think Dr. Pitts has a whole book on our website centenoschultz.com about which foods to eat and on that nutrition medicine side. So certainly eliminate those foods out of your diet. Do I believe it's going to make a dramatic difference for most patients? Probably not. Chaos Werble. I had my second PICL on Monday. You did hydrodissection of my occipital nerves. Could it take a few weeks until pain gets better? Does it have to happen right away because occipital hurts a bit like before? Yeah, Cass, we're talking about for those types of procedures, really at least a couple of weeks before you feel better, up to a couple of months. So these are not injections, for instance, like blocks, where you're going to feel immediately better, because these injections depend on growth factors doing their things on nerves, and that takes a while. Michaela, I have true allergies to both chlorhexidine and betadine. Would this disqualify me? In Kansas, I cannot find upright MRI facilities. Where should I pursue DMX or upright MRI? Do you condone Blair chiropractic? So, Michaela, I'm not sure we can help you if you've got allergies to both chlorhexidine and betadine, because both are used during the procedure. Betadine is used at the back of the throat. Chlorhexidine is used on the skin areas. We'd have to find another qualified anesthetic that you weren't allergic to. Now, when people say they're allergic, what allergic means is that you go into anaphylactic shock. So that means that you start to get wheezing, you can't breathe, you get hives, etc. It doesn't mean that they irritate your skin. So we'd have to clarify all of that. As far as being in Kansas and finding upright MRI facilities, I think then what that means, Michaela, is you'd probably want to undergo a telemedicine with one of the other doctors, not on my schedule, because my schedule requires that you have the right imaging. And then you could come out here and be in a flex slot. A flex slot means that you can get imaged while you're here, whether it's an upright MRI or a DMX, and then the appropriate procedure can be applied based on what is found on that imaging. And then as far as condoning Blair chiropractic, yeah, Blair is great. Mark, I have lower cervical instability and also believe instability of the acromion and scapula and clavicle. Always have my C7 and T1 rotated forward on the side of the AC joint injury, even 1 year after extreme stem cell treatment, lower cervical and upper thoracic by Dr. Merkel. Is it possible that a hypermobile scapula acromion clavicle could be causing my C7 T1 to be constantly twisted? I think I'm also getting nerves pinched between the clavicle and the first rib. So, Mark, these are questions probably better for Dr. Merkel. I can say that the first thing that would come to my mind would be if you've got any scoliosis, because scoliosis causes rotation in vertebra. So that'd be the first thing I would think of. But again, these are more questions for Dr. Merkel, since he knows you better as a patient. Nova, what's the average cost for an ePICL? It tends to run about $12,500 for an ePICL procedure. Nova, one last question, doctor, or Nava, sorry. If I have SI joint pain, is it okay for the ePICL? Because I think the bone marrow is moved from those areas. I may be mistaken. Yeah, not from the SI joints, but from the PSIS area. And a good chunk of our patients that undergo ePICL procedures have SI joint problems. And many times we're treating the SI joints at the same time we're treating their upper neck. Obviously, if you're local, you may want to get the SI joints treated before all of this as well, because you've got that option, whereas someone coming in from, obviously, London doesn't have that option. Keith, hi, Dr. Centeno. I'm in Singapore with symptoms that may be CCI, not officially diagnosed yet. Do you have anyone here who does PRP or the upper cervical issues, or any good surgeon here? So no good surgeons in Asia that I know of that do upper cervical fusion all day, every day. And no one that I can recommend outside of Colorado to do high upper cervical work. Now, I have a video coming out sometime this week that'll go over and try to help patients that are trying to get upper cervical injections outside of Colorado. We don't recommend it, primarily because we've had one situation where we told the mother of a patient that the patient needed to stay in Colorado. She took the patient outside of Colorado to a fairly experienced interventional spine guy, but he wasn't as experienced in upper cervical spine in the Northeast. That guy proceeded to stick a needle into the brainstem and inject, and that person had a brainstem stroke because he just didn't have enough experience in the upper cervical spine, and that was a tough patient to treat. So it's one of the reasons why I don't recommend outside of Colorado, but there is a video coming out this week. So check my YouTube channel. That'll provide you some more information on that process, at least, of how you might try to find someone locally who could help. Michaela, with the constellation of my symptoms, I am realizing an increase in both my resting heart rate and resting blood pressure, yet I'm also realizing perpetual rhinorrhea, postnasal drip. The former to me indicates less vagal activity and latter increased vagal activity. Yeah, Michaela, there's so many different things that can cause rhinorrhea. I couldn't even put a vagus nerve component on it unless that person had been through multiple different types of ENT workups or other workups to identify what's causing the rhinorrhea. So really, the answer to that question is the rhinorrhea probably has other causes, and that needs to be thoroughly investigated. Snowmass, for congenital cases with symptoms, is it more of a transverse ligament state versus whether unilateral or bilateral, where consideration for surgery recommendation is made? I'm not quite sure what the question is here. So the thing we're going to look at with regard to the transverse ligament is that ADI, or atlantodental interspace. So the first thing that needs to happen is movement-based imaging, where we're looking at the ADI. DMX is good for that. Even routine flexion extension x-rays with maximum flexion and maximum extension would be good for that. Then we've got to get from that, is it worth, or is there evidence of a lot of instability, and is that patient on an ePICL track or on a surgical track? So hopefully that answers that particular question there. Zach, example case for BMC volume 150 pounds, hematocrit 43. Would there be enough BMC for PICL and treating one or more other areas before considering PRP? Yeah, Zach, a lot of it would also depend on age. So in general, we could probably get to treating one or two more sites with that kind of information, but a lot of that would also depend on your age, meaning that you're likely to have more cells if you're younger than if you're older, and what it is we're treating in those individual spots, for example, the knees. Nava, can CCI cause tinnitus? It can cause tinnitus, yes. Cynthia, I'm trying to understand this. So can the ePICL fix or increase the CXA? Cynthia, there really isn't a need to change the CXA. What instead is happening, and I've got a number of different videos on this, is that with movement, usually the CXA is getting too low. So many times for most low CXA patients, that's looking down. So the goal is to reduce the collapse of the CXA, let's say inflection, not to increase the CXA. Meaning there's lots of people walking around with low CXAs who don't have any problems whatsoever. So again, patients get very focused on these numbers and they say abnormal number must be made normal. Doesn't work that way, not in real life. Robert, is there regen treatment for bursitis, i.e. shoulder? Yeah, Robert, a lot of times we're going to get into what's causing the bursitis, but you can also inject bursitis in general in the shoulder, like subdeltoid bursitis with PRP. It works very well. Happy to help, Nava. Ben, is it common for driving, being in a car, even when not moving the neck much to cause flare-ups? Do you have a hypothesis on why this might be? Yeah, Ben, usually with driving, Well, it could be a couple things, right? One is your car seat is putting your overall posture in a different position. In addition, even if we're in a car, we're not driving, we're usually looking around, meaning if we're not moving, just to make sure we're not going to get hit, etc. So that those would be the two things off the top of my head. Comments on laser therapy. I don't think we have much data that laser therapy is going to help if you have CCI. I don't think it's going to hurt. So if you want to try it and you've got lots of extra resources that you're willing to spend on that, and that spending those resources is not going to limit other treatments, then sure, give it a shot. Will it be possible to see a real PICL provided by qualified staff in Europe the next few years? Unlikely based on the behavior of European physicians I've seen to date. So regrettably, the two physicians that have really kind of screwed a lot of patients over because neither of them had the qualifications to do this or the training to do this. They were asked to stop. They wouldn't stop. They were asked to stop to protect patients. So because of that experience, I doubt that we're going to get to Europe for quite some time. We will. Like I said, we're working on training a Florida clinic right now. That starts in a couple weeks here with one of their doctors coming out in August. And because these guys are going to sign a U.S. applicable contract that if I don't feel they're safe doing this, that they must stop it. I don't see that being applicable in Europe. So regrettably, based on the behavior of the two European doctors to date, I think it's very unlikely that I'm going to teach any European doctors anytime soon this stuff. Having said that, once we get to training more U.S. doctors, there'll be probably better U.S. availability of this for sure. Ben, we're looking at treatment options. What would you recommend as an approach, i.e. start with more conservative care? Yeah, Ben, that just depends on what you have, right? So for example, there's 8 different types of CCI. If you had a type 3A CCI and you had tried good physical therapy, let's say through an IPA physical therapist, and that wasn't working, and you tried upper cervical chiropractic with a good provider and that wasn't working, then the next step for that patient would just be simple ligament prolotherapy posteriorly done by someone who's experienced with ultrasound guidance. If you had a type 2B, then that's not the next step. The next step would be an ePICL. So again, there are different forks in the road depending on your diagnosis. John, am I getting craniocervical therapy massage maybe? My provider says, okay, that I flare after. Should I continue? Not sure. Moving cranial bones is good 3 months after PICL. By the way, PICL 1, massive improvement. Well, great to hear, John, on the PICL number 1. Yeah, John, if you look at the rehab videos that I have online, it talks about threading that needle, right? And that is, if you're doing a treatment and it's giving you a substantial flare-up, then I probably wouldn't continue, because really when I talk about threading that needle, it's you want to, let's say, strengthening, right? You want to do some strengthening. It might aggravate things a little bit, but you can notice week over week or month over month, you're getting stronger. And that's a good example of threading that needle. But let's say we go to strengthening and instead, for every one strengthening session, you can't function for 3 days. Now you've crossed that line, right? And you're not threading the needle at that point. You're really going backwards. So it sounds to me, without obviously more information, that the kind of thing you're doing is probably not a net positive. Angel, do we need to wait for a 4-month follow-up discussion next PICL to see if we need another? First PICL has helped significantly. Thank you, Dr. C. Well, great to hear, Angel. You don't necessarily need to wait. If we believe that it's likely that you're in the category that you're going to need multiple treatments, we can usually get that scheduled sooner rather than later. It's only in those patients who we believe might need fewer treatments that we'd probably need to wait. So I would just reach out to Anna and or Ryder and or myself, and we can try to see kind of where you are there. How common are inject injuries? Not quite sure what that one means. Doctor, you have saved me with PICL 1.5 years ago. Thank you. Procedure far enough for my neck instability. Well, so great to hear, Eden, that worked well for you. Seems like we got a lot of good PICL outcome people on here. So thank you for sharing your results. Zach, what's the optimal time between bone marrow extractions? Usually, Zach, we say 3 months. That's based on U.S. blood banking guidelines. Now, having said that, if we really look at the pathophysiology of taking bone marrow out and having bone marrow replace itself, it's probably fairly quick and probably quicker than that. But usually we say 3 months as a guideline. Michaela, both cause rash. Yeah, Michaela, so sounds like more of a topical sensitivity than a true allergy, meaning a true allergy or being allergic to something causes an allergic reaction. So, probably the best thing to do would be skin wheel testing of various things to try to see which antiseptic agents you could tolerate. And that's just basically injecting a little tiny bit of that in a skin wheel and trying to see how you react. And then also injecting some saline and other things as controls, and you don't know what got injected where, then we look at that afterwards to see what's going on. Would isopropyl alcohol 90% be a reasonable substitute? Not really in the pharynx. No, that'd be a rough one because the pharynx is, unlike the skin, that would work on the skin probably, but the pharynx is going to absorb some of that alcohol. So probably not a good thing to use in the pharynx. Nava, could nerve blocks or cervical facets, MBBs, cause more damage to CCI? Yeah, so medial branch blocks and radiofrequency ablation is contraindicated in CCI, meaning it's not something we should do because those shut down muscles that are there to help stabilize. So we don't want to go the direction of making the patient weaker when they need all of the muscles they can get. Real, 5:35 p.m. maybe, Lisbon, Portugal. You're successful complete ACL tear repair with PRP and stem cells. Oh, great to hear. Thank you. Raj, hi doctor. Are you about to look at scans and symptoms diagnose CCI so I can inform my doctor? Not sure what that question means, Raj. Does it mean that you submitted your scans already? So I'm not sure what you mean by that particular question. Doctor, any injections to the neck should be more than X-ray or CT guided. Yeah, Raj, it really depends on what we're injecting, right? So for example, if we're injecting a deep cervical facet joint, that's serum fluoroscopy, which is real-time X-ray plus contrast. And if it's in the upper cervical spine, plus digital subtraction angiography. If, on the other hand, we're just doing higher dissection around the greater occipital nerve, that would be ultrasound. So it really depends on what we're doing. Cynthia, has Stanford or UCSF, Mayo Clinic, or other approach CCI treatment for you learning the PICL? No, Cynthia, and I don't think, we're not going to invite people based on they work at a fancy medical center. We're going to invite people to get trained on this because, number one, obviously they've got an interest in specializing in this area. Number two, they have the base skills to pull it off. And then number three, they've got the facility to make it all work. So for example, in this particular case, they would need serum fluoroscopy with a digital subtraction angiography package. But that's not cordoned off in the radiology department. That's theirs to use on these procedures. So again, not going to go based on working in fancy places because in my experience, all those fancy places are really, really behind in regenerative medicine. For example, I put together the Interventional Orthobiologics Foundation criteria. It's since been updated. That was many years ago. We've trained about 600 people, and That's included people at Mayo Clinic and Stanford, etc. Why would people like that come to these courses? Because those places have a dearth of regenerative medicine knowledge, and those doctors need to get it from private foundations like IOF because it's not taught where they are. So, if anything, those places would tell me that those doctors are behind the curve, not ahead of the curve when it comes to regen med. SNOMAS, can ADI be measured from DMX or only upright MRI? Either one. In fact, it would be more accurate off of DMX because sometimes in upright MRI, it's hard to know where to set the cursors because it's hard to tell where the bone stops and other tissues begin when we're at very small scales like that, whereas on a DMX, it's much more obvious. Sure, Snowmass. Happy to do it. As you know, I like answering questions. I do a lot of it. And I'm glad patients find it helpful. Mark, what does a high ADI mean? I have atlantodental instability, no big changes after PICL 2 or 3 years ago, usually a large rotation of the AO joint, one direction, C1 rotations. Yeah, Mark, so a couple of things to unpack here. The first is that we now no longer recommend a single PICL procedure. So if you didn't get a response to the first one, that should have been followed by a second one, or at least that's the way we do it today. So there's a lot of people out there that had a single PICL procedure, and a certain percentage of those patients are going to respond not after the first, but after the second. And then to unpack the other, high ADI depends on your age. So for example, if you are 60 years old, anything more than a millimeter in the ADI is abnormal. Whereas if you're 30 years old, anything more than 2.5 millimeters is abnormal. Now, why the difference with age? That's because this is a cartilage-bearing joint. And in most 60-year-olds, the cartilage has worn down. So if you see any more than a little bit of opening in the ADI, then that's abnormal. In most young people, they still have it stocked with cartilage, so that numbers get higher, the normals get higher. As far as rotations, meaning from a chiropractic standpoint, not all that important for us, because while that can be helpful from a chiropractic standpoint of putting it back in place, it generally doesn't jive with instability because there are other things that can cause it to rotate, like things like scoliosis, for example, can cause C1, C2 to rotate. 12,500, not 1,250. Keith, is craniocervical junction disorder the same as CCI? PRP isn't an option here, and Dr. I don't know who that is, Rajendra, local neurosurgeon, offers ICT fusion. What should I ask to know if surgery is right? So, Keith, we just went through that on the presentation. So if you're joining us late, then I'd recommend getting a copy of the presentation. And this will be present on YouTube and on Facebook. Facebook for 30 days, YouTube permanently. So I'd go watch that first part because that'll give you a sense of when surgery is indicated. As far as PRP is an option here, yes, you're going to have to travel if you want to get this treated. That's for sure. Dennis, are opioids anti-inflammatory? Not in general. Pia, but opioids are also are addictive, as you know, and opioids, in addition to that, rewire the central nervous system to also cause chronic pain. So being on opioids for anything more than a short period of time is not a way to manage pain based on what we know in 2025. Pia, what concentration of PRP would you recommend for a knee 50-year-old patient? High. So we're going to be at least in the 10 to 15 times concentrated number for a knee. So if you are, for example, in Europe, be very, very careful because regrettably, most European PRP kits that are available produce very, very low concentration PRP. Regrettably, we don't have that problem here in the United States. Well, we do, but it's easier here to buy kits that produce higher concentration of PRP, whereas in Europe, those kits are fewer and farther between, but about 10 to 15 XPIP. XX, I look forward to my first and hopefully last PICL next week and finally enjoying life without dizziness, nausea, GERD, and the other bobblehead. How painful will the bone marrow be and how long is it? You'll be asleep for both procedures, the bone marrow aspiration and the PICL, so you won't really or shouldn't feel much of anything during those procedures. As far as the bone marrow site afterwards, it could be anything from I didn't feel a lot there at all to feeling like someone sort of kicked you in the butt in that area for 3 to 7 days. Whoops. Just jumping around. Cynthia, thank you, doctor. Yes, Stanford, UCSF. Incredible disappointment. Yeah, Cynthia, I would agree. I think regrettably in large university medical centers, we don't have much CCI expertise. Now, there are a few California medical centers, for example, that have a lot of expertise in CSF leaks. But when it comes to CCI, that's just, I don't know of a single large university medical center that has a lot of expertise there that I could recommend. Anja, Dr. Centeno, have you received my DMX samples? I sent them to you a while ago. I'd have to know, Anja, did you send them to me directly or did you send them to ISIS for a telemedicine? So I don't know which. Let me see if I can get the spelling here. Okay. Yes. So I pulled up the email. I'll get back to it today. That's my bad. I think that came in about 10 days ago, so I hadn't gotten to it yet, but I'll get to it today. Thank you for sending those. Real, is Erin Dotson still your clinical research director? She is. So tell her, hello, I'm doing great. Now I can run, jump, train martial arts, no problems. Thanks to your team, Broomfield, Dr. Williams, and Dr. Zwicke. Well, great to hear. I think you're the patient that told me that you're from Portugal and you were chiming in from Portugal and had the ACL treatment. So wonderful to hear. And I will tell Aaron you said hi. Nimrod, I have scoliosis and C1 rotation. Would working on fixing the scoliosis also fix the rotation? Yeah, scoliosis leads to rotation of vertebra. So if that's what's causing your issues at C1, C2, i.e. rotation, then yes, working on the scoliosis is a good strategy. XX, I also forgot the daily pain at the base of my neck and into my traps and thoracic area. Gotcha. Yep, I see that up there. I got all that. Andreas, what makes one PRP kit better than the other? Why does one kit produce a higher concentration than others? I thought the main factors are the volume of blood process and the use of a double spin. Yeah, Andreas, lots of different variables can impact and affect the way PRP kits function. Hold on a quick second here. So that's everything from the method of isolation to the input volume to the centrifuge speed and everything in between, meaning that at Regenix, we developed a PRP kit. We have the lab-based method, and we developed a PRP kit that's 510K approved. And from that experience, there's lots and lots of different things that impact all of that. So PRP kits are vastly different in what they can achieve based on largely their design and how that design is supposed to interact with the volume of blood and how that's supposed to interact with the centrifuge speed and the steps that you go through in order to isolate. So for example, the average platelet isolation efficiency for a PRP kit is about 40%. That means that only about 4 out of 10 platelets is concentrated, 6 out of 10 is thrown away. Now you would say that's nuts, right? Why would you do that? The predicate we used for the Regenix kit could isolate 70%. So that's much, much better. Now you're only throwing away 3 out of the 10 platelets. And our Regenix kit got to about 85%, which is about as good as it gets. So as you can see there, huge differences just based on platelet isolation efficiency, i.e. Keeping and concentrating platelets versus throwing them down the drain. Okay, guys, well, that is 1 hour and 6 minutes in, so I think I'm going to start wrapping this up. I want to thank everyone for great questions today. And again, give us a like and a share and a comment and a subscribe and all that other stuff. Mainly a like before you leave if you haven't done so already, because that's how other patients find this. And we want other patients to find this content because that's how you pay it forward in the CCI community. Everyone have a great week, and I'll be back next week with something else. We may even interview someone next week. We'll see how all that goes. But you have a fantastic week, and thank you for all the great questions.